Hello, so this documentary is just a quick thing on obesity stigma and patient stories.
Hi, my name is Ben Whelan. I was in hospital at one stage for an MRI and the radiographer came out to the waiting room where I was sitting in a gown that fitted me nowhere. She said in front of everyone there that I would not fit in the scanner, but that I had two options. I could either wait until the bigger scanner was free, or I could make a further appointment telling reception that I needed to use the bigger tunnel. Needless to say, I waited, and I always made sure in future to make the receptionist aware that I needed the bigger scanner.
Hi, my name is Maura Murphy. I went for internal promotion in the civil service, and my line manager told me afterwards that it's such a pity that I hadn't lost some weight for it, because that would have made such a difference. I never went for promotion again. Turned me off it.
Hi, my name is Bernadette Keenan. At the age of 18, I was admitted to hospital for severe psoriasis. When they went to take my weight, the scales used wouldn't actually take my weight. So a nurse brought me into the main kitchen in the hospital and put me on the meat scales in front of all the kitchen staff. To this day, it has an effect on how I feel about myself.
Hi, I'm Susie Burney, and I went to go on holidays one time, and I got on the plane and I walked down the aisle with difficulty, weighing 25 stone, and got into my seat, and I asked the air hostess for a seatbelt extender, and she said very loudly, "We'll have to wait and see, we've quite a lot of children on the flight today and we might not have enough." And they went through all the procedures of helping people sit down, and the plane literally nearly ready to go before I found out I had a seatbelt extender. And to be honest, I had these thoughts of that I was going to be marched off the plane in shame, and I've never forgotten it.
Hello, so I am Stuart Flint. I am Associate Professor of the Psychology of Obesity at the University of Leeds. I'm also the company president for Scaled Insights, which is an artificial intelligence company. And finally, I'm one of the directors for the charity Obesity UK. So, firstly, it's a privilege to be able to give this talk on weight stigma and discrimination. It's a topic that is extremely important, and the importance of this topic has certainly increased over the years. And as we've gathered more information, more insights and more evidence about the prevalence of weight stigma and discrimination, but also about the potential impact and implications of experiencing stigma and discrimination for society as a whole. And I'll try and draw on some implications, of course, for healthcare, given the audience for this talk. So, what we should be well aware is that weight stigma is pervasive. It's reported by people right across the population. But when we're talking about weight stigma and what weight stigma ultimately is, it fits along this continuum, and there's a load of different types of terms and language that ultimately is used to refer to weight stigma. What I'll firstly say is that stigmatizing perceptions or attitudes are reported to people of all body shapes and sizes, and so weight stigma may reflect stereotypes, for instance, about people right across the continuum. But what we typically talk about when we're talking or referring to weight stigma is stigmatizing attitudes and behaviors towards people living with obesity. But even then, there's different terms that are used. So we have weight stigma or obesity stigma, we have weight bias, we have weight discrimination or obesity discrimination. What we also hear a lot, particularly in the media, is use of fat shaming, for instance. But it's critical to talk about these in different instances because they are quite different. Of course, stigma refers much more to the attitudinal or cognitive element. Bias, which may well be displayed in both attitudinal or behavioural ways, and discrimination, which typically is much more behavioural. So they are quite different, but what we also do know is that these attitudinal components, so stigmatising attitudes, do predict discriminatory behaviours, and we've seen that across a number of different settings. But it's important to really discuss those. And right at the start, I really mentioned about stereotypes, and stereotypes, of course, are key here. There's a lot of different stereotypes that are attached to people of different body shapes and sizes, and of course, you'll be well aware that the stereotypes most commonly associated with overweight and obesity is stereotypes around laziness, slothfulness, as well as gluttony. But there's a lot of other stereotypes that are also associated with obesity, which we're probably not as aware of. But actually, when we reflect on the types of information we receive, we'll know that they are very evident within our society, and they could be, for instance, being less sexually attractive or less physically attractive. They could be around friendship and being perceived as less likely or less preferred as a friendship choice. Lower intelligence is often associated with obesity, and so on. So there's a lot of different stereotypes associated with body shape and size. As I've already alluded to, it's pervasive. It is reported right across society. It's reported by people of all ages, backgrounds, and so we actually do know that, for instance, people of a very early age report stigmatizing attitudes. In fact, we have seen evidence from children as young as 3 who report some stereotypes relating to body shape and size that are often directed towards people living with obesity, or maybe characters living with obesity that are in the media. And of course we see stigma reported both on a conscious but also on an unconscious level towards people. And I probably should have mentioned that on the previous slide, but there is a distinction there. In many instances, people will report stigma very consciously, very explicitly, so they'll be very open with their negative attitudes or beliefs about overweight and obesity, but in many instances it's also unconscious, and actually it's because I guess these stereotypes have really become so ingrained within our society that we're probably not aware of how we're behaving, potentially behaving differently towards people of different body shapes and sizes. And again, that could be across these different types of settings, so possibly in education or possibly in healthcare, where we maybe talk to or communicate or even behave differently towards people based on their appearance. This isn't a holistic list by any means of the imagination, but these are just 6 areas where we've accumulated a wealth of information to demonstrate that stigma is pertinent. So of course in education, and here we see lots of evidence around the experiences that young people may well experience in schools and education centres, which include of course bullying, teasing, weight-related teasing, very common, victimization. These occur in certain educational scenarios more often, so for instance in PE class or other physical activity related scenarios, and these can have quite a dramatic impact on children's engagements, enjoyments of education, and potentially of course impact attainment. We also know, of course, that has a dramatic impact on children's mental and physical health as well, and we know that, for instance, experiences of weight stigma and discrimination are associated with, in children, increased body image concerns, physical anxiety, lower self-worth, and this can have a really dramatic impact on children, and may in some instances, and some evidence has demonstrated that these types of experiences also lead to, for instance, self-harming and other. Excuse me. Another setting which we, I should actually just quickly say there as well, is that actually weight-related teasing is the most common form of teasing that's reported by children now. So actually, weight stigma is very pertinent in education settings. The workplace is another scenario, another setting where there's ample evidence. Evidence has demonstrated that people are overlooked for jobs, overlooked for promotions, experience stigma from fellow employees, from management. Some work in the US has even demonstrated that people living with obesity, doing exactly the same job as somebody living without obesity, will be paid less, and in some instances are expected to work longer hours, And so actually stigma discrimination plays out very strongly within the workplace, and this is one setting where actually in many instances there is a lack of protection for people who may well experience stigma discrimination from other people in this scenario. And the third is the media, and probably alongside healthcare, the media is extremely stigmatizing, or at least evidence has accumulated to demonstrate that stigma is very evident in the media, both traditional and now new media, of course. Social media has certainly had a boom that has demonstrated the amount of information that actually is very stigmatizing about overweight and obesity. Some work that was published in 2015 demonstrated within a short period of time the thousands and thousands of different comments related to obesity and weight that's posted, and a good proportion of those posts were very stigmatizing. But media is clearly a vehicle that actually, in many instances, encourages the development and maintenance of stigmatizing attitudes and perceptions, and is clearly a vehicle that we need to consider in terms of the rhetoric, the narrative, and the framing of overweight and obesity that's often influencing many people within the population. Exercise and physical activity settings. So yes, I've mentioned that in relation to education settings to some aspect, but of course, again, throughout the life course, we've actually published ourselves, but many others, of course, around the world also, that people have very stigmatizing experiences in exercise and gym facilities, for instance, and other, which may well be from fellow exercisers or from personal trainers, fitness instructors and other, which again can impact people's engagement. And it's probably something that we need to consider if we are working with people living with obesity, potentially referring people to exercise or physical activity settings. So we need to be conscious of the types of settings that we may well be referring people to, and potentially increasing their likelihood of some of these negative experiences. Healthcare, as alluded to, there's actually a wealth of evidence that demonstrates that healthcare professionals hold very stigmatizing attitudes in some instances relating to obesity, people living with obesity. A lot of this work dates back to the 80s. There was a study conducted in 1987 by Price and colleagues that demonstrated not only that physicians held stigmatizing attitudes, but saw weight management and ultimately discussing weight management with patients living with obesity as inconvenience, and around 1 in 4 physicians were unlikely to actually intervene with people where there was a need identified to potentially support weight management. And then, of course, in policies and campaigns, and again, there's been a lot of information about this. Of course, here is the Cancer Research UK campaign that was heavily criticised for some of the stigmatising rhetoric and framing of the campaign. But it's one of many examples that could be identified that come from government or major health-related organisations, and maybe even charities. You may be aware of this report that was published in 2018 by the All-Party Parliamentary Group on Obesity. I think actually the report was probably designed to talk more widely to the landscape of obesity services, but actually a lot of the data and a lot of the information that was collated within the report was very much related to stigma, and these are the key inquiry findings. I'll only talk about a couple of these, but I think these are really important. So we see that 88% of people living with obesity were reporting having been stigmatised or criticised, abused as a direct result of their weight. 26% of people living with obesity reported being treated with dignity and respect by healthcare professionals when seeking advice and treatment for obesity. And I think that's a really shocking statistic, that one, because ultimately you would hope that 100% of people, everybody, no matter whether what their reason would be for going to healthcare, is treated with dignity, treated with respect by healthcare professionals. So the fact that only 1 in 4 people living with obesity are reporting being treated with dignity and respect, I think is really shocking. And then one other that I'll quickly mention there is that 42% of people living with obesity did not feel comfortable talking to their GP about their obesity. And again, I think that's again a really shocking statistic, because ultimately we want people to feel comfortable, to be able to talk openly in a safe environment with a trusted healthcare professional. So what are the implications? And actually it's been picked up quite recently in a number of different medical GP related journals. This was actually picked up in the British Journal of GPs, and ultimately demonstrating that that stigma and discrimination is critically important to this profession, but actually more generally across healthcare. And the potential here is that these experiences of stigma and discrimination, both in healthcare itself, but actually more generally in society, actually may impact the effectiveness of healthcare interventions, policies, campaigns, or other. And in many instances actually may lead to inequalities in the care that people may experience. And again, I think this is critically important as we are becoming more and more focused in society around equality, inclusion, diversity, and actually I see this as very much a process around inequality that we need to address within society. And of course, from an NHS standpoint, it actually goes against the core principle if people are not receiving fair, equitable healthcare itself. Because the core principle, of course, is that the NHS provides comprehensive service and is available for all. What's the consequences for people living with obesity? And again, I alluded to this earlier, but it's critically important that we understand the consequences of stigma and discrimination. Well, what we actually know, and evidence is quite large now to demonstrate that these types of experiences are associated with mental health concerns, so depression, anxiety, body image concerns, it impacts self-esteem. So we know there's a direct relationship between weight stigma and mental health. We also know associations with physical health, so cardiometabolic risk factors have been shown to be higher for people experiencing stigmatizing having stigmatizing experiences. But beyond health, we also know that it impacts behaviour. Actually people respond maladaptively. So experiences of weight stigma discrimination reduce the likelihood that people will engage in health promoting behaviours. And what we actually know is that in some instances increases unhealthy eating related behaviours, decreases physical activity related behaviours. It reduces the likelihood that people will attend or seek healthcare or medical support or advice. So actually, again, weight stigma has a very detrimental impact not only on health but on behaviour. It leads to disempowerment, it reinforces stigma, and in some instances may lead to weight gain. So ultimately it may impact the effectiveness of healthcare, engagement with healthcare, and overall behaviour change, which in many instances interventions are looking for. So what does this ultimately do? It speaks against the common myth within society that weight stigma can be beneficial, and I'm sure many of you would have seen this before. Maybe you all would have seen it, I would expect actually, because there's been quite a lot of information, particularly in the media more recently, that suggests to the public that stigmatizing experiences can actually be beneficial. Well, we know that they can't actually. We know that stigmatizing experiences are very detrimental for people. What I also wanted to quickly mention here, and I came across this clip in a program, I think it's called Blue Bloods, And I came across this clip coincidentally. I went to present in New York and US drama, and it actually came out the day after I landed in the US, and it was very timely, let's say, in terms of my arrival there. But I wanted to highlight this because not only are people living with obesity stigmatized, but also different types of weight management related behaviors are stigmatized more. And again, this goes back to those stereotypes around gluttony and slothfulness, and ultimately that with greater effort and more willpower as such, if people lose weight through those means rather than, for instance, bariatric surgery or other, they're perceived to be much more positive, and people are less likely to be stigmatized because we value these. We have different types of value related to these different types of treatment that speak to what we often coin as kind of effort-related interventions. And so, this clip came up, and I thought it was critically important, and I should show this. But just quickly here, in terms of information that's very evident within this clip, but also more generally about treatment and stigma relating to treatment that's associated with obesity. Often, it gives people, the general population, a limited understanding of what weight loss surgery actually is, the complexity of weight loss surgery, and ultimately the long-term impact that this might have on people. It's very simplistic in terms of the amount of information that it provides. As I mentioned earlier, often there's a gendered narrative, so stigma directed towards females is typically much stronger than stigma directed towards males living with obesity, and again promotes some weight stigma. So I'll play the clip, but this is just one of many examples I could have provided.
What the hell?
You knew you couldn't climb the career ladder carrying all that lard. Some might call that hypocritical. I sure do.
Where'd you get this?
You did a pretty good job of scrubbing, but you missed a few from the 90s. During your time with the Baltimore PD?
Doesn't matter what I did.
And what did you do, Johnny? What do you call it?
Gastric bypass.
Cosmetic surgery?
More than just a tummy tuck. I mean, imagine if that got out.
I mean, it's not like you even sweated off the extra weight. Discipline yourself, set an example.
You took the shortcut.
Rank and file is going to eat you for lunch.
Not if this exam puts those same officers out of a job.
And so again, I could have chosen a number of different clips to demonstrate that stigma is very evident towards weight management more generally, and weight management related efforts, or often coined as treatments. And for some treatments, stigma is much stronger. And bariatric surgery has certainly been one of those treatments that has been stigmatized very much so over the last 5 years or so. And if you really wanted to know what the potential impacts of this type of media information has on individuals, then you only have to look at the different types of comments that are left underneath YouTube clips and other, and this is the potential impact of this type of rhetoric and framing relating to obesity. So what are the societal messages, and what I've tried to do here is identify ones that are most relevant to healthcare in particular. These are very consistent messages within society. What we've steadily seen is an increase in messages that tell people that NHS spending, NHS treatment, etc., always should be ranked, and in the majority of instances, treatment related to overweight and obesity is suggested to be much less important compared to others, or other health conditions, or other ailments, or other. Again, very much around the cost to the NHS. And again, you'll see lots of different stereotypes being used and terminology being used within these types of media portrayal. Very much focus on individual responsibility, and given the complexity of obesity, the many different factors that contribute to obesity, very much against the empirical evidence. So what we're ultimately telling people is that there's very much an individual focus, that it's about a lack of willpower. We're telling people that obesity is very simple, when in fact, of course, it's very complex. What always surprises me is that we talk very much to the acute solution. And if you look at there's many different types of definitions relating to obesity, but what's consistent throughout all of the definitions is that it's chronic. Yes, we seem to pass on a message in society that a chronic health condition can be solved with an acute solution. Well, it just doesn't make sense. But that's what we see, lose 2-3 stone within a month or whatever that might be. Very inaccurate, and you're setting people's expectations up for failure. But of course, what we also know is that longer-term maintenance of weight loss is often one of the things that some people struggle the most with. And what we also know is that stigma is much stronger when people are referred to as lacking morals, and moral condemnation, of course, is extremely evident within these messages. So what happens is people internalise these and often reinforce these as their own personal beliefs, and the amount of information that is received consistently and daily means that these perceptions or attitudes become extremely strong, and therefore very difficult to actually change. And a lot of interventions to reduce stigmatising attitudes have been ineffective because of the strength of these types of attitudes. Of course, the Foresight report, I haven't put this on here because I'm going to talk through the Foresight report, of course, but what this is really to demonstrate is that, as we all know, it's extremely complex, it's multi-leveled, multi-component. So all this information and the messages that we're ultimately giving to society is very much against the evidence. This is, of course, in 2007, over 100 different factors linked to the reasons why people may gain weight. Of course, empirical evidence tells us that this is only a snapshot, and actually there's a lot more evidence that that could be added to the Foresight information. So there's a lot of different factors, and they span across a number of different, 7 determinants or areas that these factors span. So ultimately it's extremely complex, and in reality we really need to be questioning how much choice people have. And of course, for some people there's differing amounts of control that people may have in terms of their different types of behaviours and other, but certainly this focus on individuals being 100% in control of their behaviour and potential weight status is very much ill-aligned to the actual empirical evidence. So messages aren't in line with the evidence that we ultimately see in the literature. However, we see the opposite, as I say. We see this focus on individuals, and it's often leads to blame. And I've adapted this from something that came out from Dr. Darmio, and I think this really paints an interesting picture, because ultimately, if we look at the prevalence of overweight and obesity in the UK, it's around about 2/3. So this should really be something that we should be reflecting on when ultimately a lot of our messages are very much about blaming individuals for potentially, for instance, behaviours that we describe as unhealthy, or for scenarios that people may find themselves in. And actually what we need to be looking at and thinking about is the structure and the whole system within which we actually live within. One final thing that I'm just going to quickly touch on here is the framing of obesity, and this becomes something that I really have a bit of a focus on. And I focus on this because I think one of the things that has really been lost in terms of the way that we we think about obesity and often the ways that people living with obesity are treated within society. What's lost in many instances is empathy and compassion. But actually you can see this in a lot of literature. This was some information that's, or really the overview in terms of the review of information that I published earlier this year, which was reflective of the NHS long-term plan. But actually, I've done this with a number of different policy-related documents in many different scenarios now. And actually, when you compare the framing of cancer and obesity, and I use cancer and obesity because we've come very far with cancer, they're very different, they're very distinct. And so what we actually see when we look at the framing of cancer, for instance, is that cancer and people living with cancer are discussed very positively. Often we're using terms or phrases such as the cancer family or survivors. In many instances, we actually celebrate and call for increased spending relating to cancer, for instance, discussed alongside health-related outcomes. And often you'll see within NHS documentation that you have cancer, diabetes, cardiovascular disease, and other. And there's a lot of support networks, a lot of involvement from public and patient groups, which you often don't see with obesity. And here's the comparison with obesity that ultimately is discussed very negatively. In many instances discussed as a problem. Often we're talking about high costs of the NHS, that it's a burden. In many instances, obesity is discussed as being, or at least in the UK, as the UK are the worst in Europe, or one of the worst in Europe. It is very alarmist behaviour, alarmist language. Sorry, it's very individually focused. Interestingly, obesity is often grouped with behaviours. So when a minute ago I mentioned that cancer, you see cancer alongside diabetes, cardiovascular disease, and other. Well, obesity is a health outcome, but for some reason obesity is often over here, and it's discussed alongside smoking and physical inactivity and other. Well, obesity is an outcome, certainly not a behaviour. So in reality, obesity should be over here with the health outcomes. In terms of language, often condition first, rather than person first language. And again, there's often very little indication of patient and public involvement, although that has increased over time. But actually, I think if you go back and you look at some of the different policy-related documentation around cancer and obesity, you'll see that there is a clear distinction between these two. So just to summarise then, ultimately weight stigma discrimination is pervasive in our society, but what I do want to also highlight, given that there is associations between stigma discrimination and mental physical health decrements, as well as leading to behaviours that may lead to health decrements, that is actually a modifiable risk factor, and there is a real need to end weight stigma discrimination. There's a need for all of us to make these different types of changes, to reflect on the different types of environments that we ultimately set up, healthcare as well as other, to ensure that they are inclusive environments. There's a lot of immediate changes that we can make. There's immediate changes that can be made around terminology and imagery. But ultimately what we really need is to move away from a lot of the simplistic language, the simplistic descriptions of what obesity is, but also the perceptions around the simplicity of weight management, because ultimately that's impacting people's understanding, their attitudes and often their behaviours towards people living with obesity. Okay, thank you very much.